Hey Asher, thank you so much for reaching out to me, and let's go ahead and talk through this tooth. This is tooth number 27. This is our access preparation. I mean, it's Instagrammable, social media size. What I'd say is that it's a little bit smaller than kind of traditional, but it'll work, and it depends on your magnification, whatnot. This is actually a number 0 mirror, so it makes it so much easier to get back here. So I'd highly recommend getting one of those. So let's go ahead and we'll get to the point where we're troughing. And I'll talk about this. So what we're doing here, because it's a posterior tooth, it's getting a direct composite cuspal coverage restoration in preparation afterwards if the patient wants a crown or whatnot. We're just going to cuspally give us a tooth the protection it needs after this endo is completed once it's sent back to the referring dentist. So I'm going to reduce that, and then at the end of this appointment, it gets a cuspal coverage direct composite restoration, which are fairly simple to do. So we're going to get into that access. I'm just using my long shank diamond burr from Dentsply. And what had happened was we're going into some sponge. That's what it is. So they used an endo sponge as a spacer. And let's go ahead and take a look here. All right, so let's get this in focus. So like you had talked before just about, troughing white. And certainly this is, so let's situate you here. This is the mesial buccal, distal buccal, palate, calcium hydroxide, mesial restoration. And you can see I've started to bevel this. I'm probably I think I've removed a little bit more. It's been a while since I've done this. And sort of lingual composite here. So the area that we're there's a couple tips. One I'll just share with you right now is that mesial buccal in sixes, this is a 7, but in sixes, and I'll slightly apply it to this, you can run a line from the palatal canal to the mesial buccal canal, and if you bisect that line, you can start looking at MB2 here, and then MB2 can be anywhere along this. I've also found on 7s, MB2s like all over the place, all in this area here. So that tip is not as helpful as in 6s, but what I'm going to do is I can't remember if I do it right up front here actually. Yeah, so there's MB1, and I'm trying to look at the floor, but I don't see anything here. And the floor is sometimes a useful map, sometimes it isn't. It just depends on the tooth. I mean, it looks all dark, so it's not really useful here. So let's go ahead. I am going to start troughing, and before I talk about the troughing technique, what I will do, it depends on the situation. In fresh root canals, I won't start looking for MB2, or even necrotic ones. I won't start looking for MB2 until I have at least these canals cleaned and shaped all the way down to up to my final file, which is typically will be a large wave-one gold in the palate and a medium in the buccals. And the reason why I do that is because it will kill bacteria. If it's necrotic, it'll start that process. It'll also remove all that. I'll machine out as much as that vital tissue in a vital tooth as much as possible, and then I'll let the hypo kind of degrade the rest of that pulp tissue. If I start tackling this right now and run into problems, this eats away time, and that time could be used to clean and disinfect and break down vital tissue in those other canals. So that's a really efficiency kind of thing to think about. In this case, because I had the handpiece already out, this is already prepped to a wave-one gold medium, I'm not as concerned. So I'm going to take the time while my dental assistant has her high volume suction out. I've got my handpiece in my hand. I'm just going to go ahead and trough this. That way I can, if I can visualize it, once I have my endo handpiece in my hand, then I can keep going. So what I'm doing here is I'm just using, there's several different ways. What I'm using is just a light brushing technique, and that's what's really helpful with these smaller mirrors. I can actually put the mirror back there and see what the heck is going on. Because with a standard number 5 mirror, it's really hard to get in there. So I'm just lightly brushing. I don't know at this moment because I've forgotten, but likely this handpiece is slowed down. If you have an electric, this is usually right around 70,000 RPM. And I'm just lightly brushing. I'm not even touching the floor. I'm barely touching the floor, and I'm looking for any little white dots or white lines or whatnot. So in this case as well, let me go back here. One other helpful tip is you can, remove as much of this restorative material as you need to get better visualization, get a better angulation of your handpiece. I mean, it's restorative. The tooth structure is already gone, so what I'm going to do here is I find often trying to get my, so there you can see right there, I'm trying to get my handpiece often into my endo handpiece sometimes when the patient can't open very well. Opening up, beveling this restorative material even a lot more gives you an ability to get those handpieces in there much easier. So in this case, I don't find MB2, but I'll show you some of the hints that I'm looking for. And then, so one of the critical things that I don't have a cone beam on this, and I'm not about to get one unless the conditions are set afterwards. And I've informed the patient that we finished the endodontic therapy. The patient did have, once the pulpectomy was done, the patient said it's been about 3 months. In the previous few weeks, he started having hot and cold sensitivity. So when I hear that, and this is before I sat down and did this, when I hear that, okay, so I'll finish that story in a second. So you can see MB1 really troughed all down to the floor, and I don't see any really indicators, like little white dots, that there's an MB2 here. Now, I kind of look at this one, I think. I'm kind of like, oh, there it is, but honestly, I could not get into it. So the patient was saying I have hot and cold sensitivity, so that indicates to me either there's pulpal tissue remaining in one of the canals, in my experience typically the palate, especially if it's only machined to a wave and gold primary, or there's an MB2 there. So what I'll do after this is that I'll inform the patient, like, okay, in this case, we finished the case, there was no MB2 found. I obturated, and I said, in the next months, if you start getting hot and cold sensitivity, there's a likelihood of another tunnel, well, I call it canal in this case, and then at that time, let me know, and we'll likely go ahead and grab a 3D and see if we can visualize that with a 3D scan or with a CBCT. Sorry, I'm going between patient words and provider words. So what I'm going to do next likely is, it's been a few weeks, so I'm like, most likely I'll be sending Wave and Gold primary downrange to start machining those canals. So here we'll take another look just before we start doing things. That little dot raises suspicion, but other than that, I mean, there's not really any pattern. You can see the slight, there's a little groove with calcium hydroxide between the mesial buccal and distal buccal. There's a little groove of calcium hydroxide between the palate and the distal buccal. And then I'm looking also for any other indicators of little white dots or whatnot. Okay, so I'm going to skip past this and we'll get to the point where we're just going to machine everything. Okay, here we go. So now we're at higher magnification. This white I typically don't trough in most situations. Let me just play this out slow. Boom, oh, right there. This white dot. But it turns out it was nothing. It was kind of maybe a developmental kind of defect in the dentin, I'm not sure. So I'm going to I'm not going to start troughing because that white, let's see if we can get out of here. Okay, this is actually a great example. So this white, I typically stay away from. I also see this white this color of white right before I hop into a pulp chamber. So it, like doing the access. So it's like that dentin lies over top of pulp chamber. It's the whole pulp chamber, not just like what we're doing here. So what I'm doing here, this is usually my go-to, is I'm taking my Wave and Gold yellow, and so it's the small, and if we take a look here, I don't see any. Maybe I trough this. Oh, I do. Well, there you go. Okay, so we're going to trough that just a little bit, just to see if there's a little bit of a, something hiding under there. So let's go ahead and rinse all that debris out, and let's take a better look. So full strength sodium hypochlorite. My irrigating needle is bent at 2 millimeters short of my shortest working length, just so I don't get a hypo accident. That's always on my mind, especially this case, because this palatal canal, I know we don't have the radiograph, actually extends into the sinus. So I'm very extremely cognizant of that. Okay, so, and then what you're seeing me do is I'm actually aspirating my irrigant, so I'm pulling it out of the canals to dry out this field a bit. Now, I'm pulling it out, but what's happening at the same time is that there's still hypochlorite at the apical third. So it's still, you know, the most important part of this case is the apical third, so we're still debriding, you know, breaking down vital tissue at the apical third. So let's go ahead, we're just taking a look here. The problem is we're getting white reflection from the light as well. So I'm going to take my Wave on Gold yellow. This is my go-to. If it can't make its way, it's not going to create a canal. If it can't make its way down, like now, it's not going anywhere. There's nothing there. This is an incredible file, and because I use it in this technique. This is actually a short file, so because it's a 21 millimeter, it's not the 25. 25s were used in the rest of the case. So that's where I troughed right there. I don't see, you know, here, this is kind of where that, they call it, the dental cornice meets. Usually you'll see like a little white groove or a little white dot where that cornice meets the pulpal floor. I don't see that. I don't see any little white dots. This here, still calcium hydroxide, I'm not too worried about that. This little groove between the mesiobuccal and distal buccal, not worried about that. Looking, you know, along where between the palate and mesiobuccal canal, I don't see any white dots. That's really what I'm looking for. So I'm going to call this a no-go. And I find that like in the 30% of cases, we don't have that in the upper sevens. So I'm not going to finish this whole case, just to give you an idea. So I'm taking my gutta-percha points, and this is how I'll activate two ways. I'll use negative pressure irrigation, and then I'll also use manual dynamic irrigation, which means simply I'm going to pump my canal, my gutta-percha points just nice and light a few times, not a lot. Remember, this is close to the sinus, so I'll be very cautious with this. And what this is doing is it's stirring up the apical debris, and I found that is a really simple, cheap technique, easy, and I've done these techniques on clear teeth, and I've noticed that is one of the most effective techniques to get debris from the apical portion up to get it into solution to, then we can rinse it out and remove it. You can see how translucent that irrigant is, and that's really critical. So you can see the difference here. This is one of the things I think it's hard to visualize without a microscope, the debris coming out of there. So there's debris there to where now it's clear here. Let's take one last look. I think once I dry the case too, so let's go ahead, we'll obturate, blah, 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 blah. Okay, so mesiobuccal, you know, still looking, I don't see any white dots. Oh, yeah, so I'll take my Explorer. Oh no, condenser. I don't think I take a look at the end. I'm just placing composite afterwards. Nope. So anyways, hopefully that's helpful. I think it's dragged on way longer than I was expecting. Let me know what you think. Cheers.